When we talk about structural racism, you have to talk about current situation and the long, dark shadow cast by past structural racism.
When we think about immigration status, it really determines someone's opportunities for employment, their living conditions, their access to health care, and it's a form of everyday inequality.
AI in healthcare is rapidly expanding. Biased data is an example of structural racism in healthcare.
Several studies have looked at how many Native physicians there are. For instance, let's just start with a simple question. Are there Natives who can lead the team taking care of Native patients? And it's not even 1%.
Over 90% of individuals in immigration prisons are now in for-profit prisons. I mean, these systems are mutually reinforcing, really. I don't think you can have mass immigration detention without the mass incarceration system.
We know the things that we've done in the past do not work. So we need to try something different. We need to be bold, we need to be brave, and we need to be better.
Many healthcare institutions have publicly committed to achieving health equity. However, to truly create equitable health systems, we need to understand the role structural racism has played and continues to play in the inequities we observe. Racism in the United States goes beyond slavery, the Indian Removal Act, the Chinese Exclusion Act, Jim Crow laws, and countless other events in our nation's history. It is present and pervasive in current structures and systems of society, including health and healthcare. So, what is structural racism? In Health Affairs' first Racism and Health issue in 2022, Paula Braveman and co-authors explain that structures such as laws, policies, institutional practices, and norms produce, condone, and perpetuate widespread unfair treatment and oppression of people of color. As we revisit racism and health in the October 2023 issue of Health Affairs, the goals of today's discussion are first, to depict what structural racism in healthcare looks like in our present day, and second, to discuss anti-racist methods. How can we actively identify, oppose, and dismantle racism in healthcare? I'm Michelle Coe, Associate Professor of Health Policy and Management at the University of California, Davis, and a member of Health Affairs' Health Equity Advisory Committee. Today, I'm joined in conversation with health equity experts who look at the impact of structural racism in healthcare. When we think about medical racism specifically, we have had crucial conversations around the past exploitation of and experimentation on African American and Black populations and current anti-Black racism in decision-making and treatment. These dialogues have opened important opportunities to further critically examine how health and healthcare systems throughout the country have oppressed and continue to oppress many historically marginalized, racialized communities. Additionally, racism and health issues are not limited to hospital and clinical settings. We will dig into this in today's conversation and learn how others are tackling racism in their respective areas of healthcare. Today, I'm going to start with a question for each of you. What policies, structures, or other institutions creating, perpetuating, or operationalizing structural racism in your line of work? Dr. Wescott, let's start with you.
Okay, well, I'm here to speak on behalf of Indigenous people, and I tell you, when we talk about structural racism, you have to talk about current situation and the long, dark shadow cast by past structural racism. So let's start with the present. I cared for a very sick Native child in the pediatric intensive care unit who had such a rare disease. There were only a few papers in the world on this condition, and the most patients in any paper was 8, and there was no treatment, really only supportive care and hope. That was it. The family asked to bring in a traditional healer from their tribe, and the entire PICU team, with the exception of me, adamantly opposed that. Like, all you have to offer is IV fluids and hope. So those are things where there's really not an understanding of culture and what is healing, and worked for thousands of years before Western medicine ever came to this land. To dismiss it out of hand was really disheartening.
Thank you for sharing. Dr. Diaz, in terms of your work, can you talk a little bit about the interplay of structural racism and how that shapes immigration policy?
Yeah. Absolutely. So I think that when we think about immigrant prisons and the immigration enforcement practices that really fill them and the ways in which they impact communities, we fail to really recognize that immigration policy is a structural determinant of health, and that it's really rooted in a legacy of racist U.S. immigration and criminal laws that have disproportionately impacted communities of color, and very specifically Black and Latinx communities. And from the start, U.S. immigration policy defined racial categories in our country and was used to reinforce social hierarchies. And so when we think about immigration status, it really determines someone's opportunities for employment, their living conditions, their access to healthcare, and it's a form of everyday inequality.
What do you see showing up today in the present in immigrant prisons, and how is structural racism playing out in health?
Most people are really surprised to hear that the U.S. is the world leader in imprisoning immigrants. And it's at a huge cost financially, but also to the health of individuals, their families, and communities. And so on any given day, there are over 30,000 immigrants that are forced to be in punitive conditions in a system of civil law that really deprives them of the due process rights present in our criminal legal system. And so I think that one important piece is to really make this invisible system seen, and to really recognize the ways in which it is a system that's directly placing people in harm, and that it's worked by design.
Thank you. So, Dr. Cary, we think about your work as looking into the future and the future of healthcare and technology. And I'm wondering if you could talk to us a little bit about artificial intelligence, and how this might be a part or not of structural racism in healthcare.
Yeah. So AI in healthcare is rapidly expanding, and the potential benefits are substantial. Still, there exists challenges as it relates to structural racism and advancing health equity in AI. In this context, biased data is an example of structural racism in healthcare. Using that context, the clinical algorithms that healthcare professionals use in guiding care and making health decisions can be detrimental to patients when the data that these algorithms use are biased and when they don't have the appropriate descriptors. And that has implications for really disadvantaging different populations of color.
Could you maybe speak to an example of that?
So, for example, the use of a pulse oximeter, of a ubiquitous medical device used in all healthcare facilities across the country. But we know through research that that medical device can produce inaccuracies, and particularly in patients with darker skin tones. That's extremely concerning, given that some patients are very in need of the supplemental oxygen.
So it's the worst kind of error, right? Because it's saying if you have darker skin, it can't exactly tell how much oxygen, and it overestimates.
Correct. And the data that these devices were developed based on oftentimes were based on data sets that had a lack of representation of minority groups in these data sets.
Thank you. Kind of want to go back to Dr. Diaz. If you could also kind of give us maybe an example from clinical practice or research around maybe an invisible piece of the immigrant prison system that people might not know about today.
One thing that I can speak about is the way in which anti-Black racism in particular manifests in immigration prisons. And so what we do know is that Black immigrants are more likely to receive higher bond amounts. And so that means spending more time in immigration prisons. They're more likely to be punished with solitary confinement, and they're more likely to be deported. And one of my co-authors, Dr. Caitlin Patler, published an article entitled "The Black Box Within the Black Box." And I think that really captures just the ways in which the system can harm individuals. So there's a body of evidence that has documented the harms of solitary confinement. We know that it increases risk for self-harm. And yet research is finding that its use is actually increasing in immigrant prisons. And this is including among individuals with serious mental illness. And so it's not surprising that we're also seeing rates of suicide as the cause of death skyrocketing within immigrant prisons, right? And so it's one example of how policies and practices really reverberate at the population level. And thinking about data in particular, there is not a system of accountability and transparency that is built in. And so the research, as comprehensive as I think it is, we really don't know much about the characteristics of people who are in immigration prisons. For example, the latest data that we have at an individual level is from 2015. So while we know that about 40% of immigrants are from Latin America and the US overall, in 2015, 94% of immigrants in immigration prison were from Latin American countries. But that's the latest data that we have at that level, at that granular level.
Yeah. So I think what we're hearing is not only are systems or practices that are happening are invisible, but in some sense, the invisibility is by design, what we have created. And this is where we see structural racism become operationalized. What we create to count or not count folks is part of it. And then kind of to Dr. Wescott, going back, you had mentioned about even, present day, the challenges of just asking for a tribal healer. Can you talk a little bit about kind of what structures or policies are in place that prevent or, hold back sort of the education, recruitment, retention of healthcare professionals who really are sort of the best in place to care for Native communities?
Yeah, so I think a theme you'll hear all day is the data is problematic. Sometimes I say it's a hot mess. And so several studies have looked at how many Native physicians there are. For instance, let's just start with a simple question. Mm-hmm. Are there Natives who can lead the team taking care of Native patients? And it's not even 1% of the physician workforce, but a lot of that data was collected when you graduated from med school, and it was what questions, 30 years ago, what your race was. Mm-hmm. And if you were only allowed to choose one race, maybe they didn't choose Native Americans.
We'd really like to talk about what folks are doing to tackle structural racism in healthcare. And so what I'd like to do is sort of move to that part of the conversation. And so I think kind of circling back to Dr. Cary, What do you see, what are you seeing in terms of the role of AI maybe in countering structural racism? Or what do you see in efforts to make sure that structural racism is not perpetuated in the generation of algorithms?
So there are a lot of great examples that I can point you to. Two of them that come to mind that I think are particularly impactful are two large initiatives by the National Institutes of Health. The first one is called the Aim Ahead program. And the purpose of the Aim Ahead program is to increase the number of underrepresented minorities in the development of AI algorithms. So it's really about amplifying and increasing representation of underrepresented minority researchers, as well as communities that are underrepresented in this AI space. The other example that I think is relatively new is developed by the National Institutes of Minority Health and Health Disparities. They recently have created a cloud platform called Share. And Share is a accumulation of tools and resources really dedicated to mitigating bias in algorithms and advancing health disparities research.
Do either one of those initiatives have a space or opportunity for community engagement in the programs?
So yes, the Aim Ahead program in particular has a community engagement, their core, where they're very much interested in bringing in stakeholders and members from the community to really kind of take part in the development of these algorithms. And I think that's really key. And I think that's also something that has been glaringly missing from the development of algorithms to date, is that even though these algorithms have been developed with the best of intentions, oftentimes they don't involve individuals from underrepresented backgrounds in the development or the evaluation of these algorithms.
I think I'm going to turn to Dr. Diaz. In a similar way, can you think of examples of policies or programs that are, whether it's with data or another fashion, community engagement, bringing out some of the invisible systems within immigrant prisons and really actively trying to dismantle the way they exist now?
Yes, I can actually think of a lot of examples, and I want to really emphasize that community groups have really been organizing in this space for decades, really from the onset of the system. But I think that really what has been most successful has been local organizing at the county level to really end contracts with Immigration and Customs Enforcement to close down immigrant prisons. And that organizing really in many cities has been led by people who are inside detention. And so you all may have heard of the hundreds of hunger strikes that have happened in immigration prisons across the country in recent years. And so what we see is that immigrants themselves have really been vocal and putting their own lives on the line to really bring attention to the way in which the system is failing to protect them. And what we know is that there are cheaper, more effective alternatives to immigrant prisons. Really community-based programs are just as effective at ensuring someone is present at their immigration hearing. And it is a way of really keeping families and communities together.
If you could talk a little bit more about tribes having the opportunity finally to be in charge of their Indian health services. And I wanted you to talk a little bit about how that came about.
Sure. So I'll try and keep this to the short version.
I know,
it's
it's all right.
extremely complicated, extremely quickly. But if you are an enrolled member of a federally recognized tribe, you are the only population in the U.S. with a birthright to healthcare.
Yeah.
And yet we see some of the greatest disparities. Now, the basis for that legally was actually a treaty signed in the 1800s for the most part, usually under threat of war. So, but at the time, especially even it had been a couple of years of contact, American Indians still did not have a lot of immunity to infectious diseases that some of the European settlers had brought with them. And so the somewhat cynical view is that treaty rights include health care. So this is the 1800s, which, healthcare is not much more than a cot and it's a little bit of that, but you know what I mean. But that was so that the federal government would have the legal right to quarantine Indians in the event of an outbreak. So that's the legal basis of the Indian Health Service. And so, I will say it's not, transparency is still an issue with federal data in many levels. And the Indian Health Service does not release this, but they were absolutely spectacular when it came to the COVID-19 vaccinations. And between the Indian Health Service and tribes, they were able to vaccinate their neighbors. Even in Canada, there's a beautiful picture of a whole line of cars waiting to come up and get their shots. So they do some things very well, but they're chronically underfunded, and it's all tied together, as you asked earlier about representation in medicine. So less than 1% of Native American physicians in the physician workforce, but 15% in the Indian Health Service. But I think because you don't have enough Native physicians, there's chronically 25 to 33% physician vacancy rate in the Indian Health Service. You imagine doing your job when you're a quarter or a third short of just the physicians you need, and that's just the top tier. And every level, there's those issues. So we still have a long way to go.
Yeah. And so some of the structure is the Indian Health Service as a whole, but the funding and the way it's funded.
Absolutely.
Got it.
And that actually, like that point that you just made, Dr. Cove, really, the way that funding works to reinforce these systems, but also to perpetuate racism in these systems is really important, because that's where we get to the policy matter, right? And so in the case of immigrant prisons, in congressional appropriations bills, it's actually been written that we need to fund a minimum of 34,000 beds. And so it's not surprising that when you tie funding for the system to filling these beds, that they will be filled. Yeah. And a recent ACLU report just out 2 weeks ago demonstrated that over 90% of individuals in immigration prisons are now in for-profit prisons. And so there really is this financial incentive to maintain the system, and that's part of what we're pushing back against too. So these are very large economic and political forces that are shaping health in so many ways.
Yeah. So what you're describing is really kind of already what we saw, for example, with the prison expansion in the 80s and 90s, right? And the war on drugs, and this idea that we would put funding that mandates a minimum amount of incarceration that has to happen. And that is being just replicated again within the immigrant prison system as well.
I mean, these systems are mutually reinforcing, really. I don't think you can have mass immigration detention without the mass incarceration system. And the same policies that criminalized particularly Black communities, but other communities of color, in the 80s and 90s is what has really created a pipeline into immigrant prisons, because that is one pathway in which people end up in mandatory detention.
So we can always go back to funding, and we can always go back to data when we talk about structural racism. And Dr. Cary, on the funding side, what do you see are sort of the funding incentives or disincentives to address racial bias in clinical algorithms?
We have at the Duke University Health System a robust AI governance infrastructure. And what's really great about it is that we have a lot of different experts and diversity of expertise, from quantitative scientists to ethicists to nurses and physicians. And all of us are working together to ensure the safety and the equity of these algorithms in healthcare. But that's at Duke. But if we were to go up the road 30 miles to some of the low-resource counties and communities, a lot of those health systems and those small hospitals don't have that infrastructure at all. So I'm concerned about how financial resources will and will not reach different facilities based on where they're located and the type of patients that they care for.
Thank you. And I think what I'm hearing from all of you too is that the other important lesson I'm taking away from this personally is that a reminder to everyone that the expertise is there. The communities have expertise already. We don't need to go looking for something new. We don't need to go looking for other people. And what we really need is humility and engagement.
Well, I will say there's a movement to go away from cultural competency to cultural safety.
Yeah.
Just anybody should feel comfortable with you. That should be the goal.
All right. And then the final question is, what advice would you give to others who are working truly to try to actively create anti-racist structures and systems in health and healthcare today? We will go with Dr. Cary.
Sure. When I say that we need to be bold, we need to chart a new pathway in healthcare education, healthcare training, and healthcare delivery. When I say that we need to be brave, we need to speak up to the injustices that we see, and we need to encourage colleagues to acknowledge those injustices. And lastly, when I say we need to be better, I love Maya Angelou's quote, which is, do the very best you can. And then when you know better, you do better. We know the health system is broken. We know it has poor incentives and it produces bad outcomes. So we really should be talking about the creation of a new healthcare system that works for all of us and not certain segments of the population.
Dr. Diaz, words of advice.
I think that it's extremely important to really center and elevate the voices of community members in all of these discussions, in our research, in our policy discussions. They really need to be at the forefront and center. But I also think that as researchers and people working on improving our health systems, we really need to be taking a critical and intersectional approach that is really focusing on the systems and structures that are driving these inequities. So I think that we have enough data and research that has well documented the disparities, and we really need to start tackling these systems.
All right. And Dr. Wescott?
Well, I have two pieces of advice. Stick together. Find each other and find your allies. They aren't necessarily your same race, but they're out there. And then when you feel like it's impossible, which really almost everyone will get to. At least I haven't met someone who hasn't gotten there. Remember where you're from. Get back into your community. Go to a potluck, whatever it is. Remember why you're doing this, because it's really easy to feel discouraged that the system is never going to change.
Well, thank you again. Thank you, Dr. Cary, Dr. Wescott, Dr. Diaz, for sharing your time and insights with us today. And thank you to Health Affairs for sponsoring this session.
Read our full October 2023 issue of peer-reviewed research dedicated to tackling racism in healthcare. The issue features articles that expose various forms of racism in healthcare that contribute to health inequities among racial and ethnic groups, while providing strategies to potentially circumvent it. Thank you to the funders who made this issue of Health Affairs on Racism in Health possible. This includes the Robert Wood Johnson Foundation, the California Wellness Foundation, and the Episcopal Health Foundation. To learn more, make sure you check out our entire Health Affairs issue dedicated to tackling racism in healthcare at healthaffairs.org. If you enjoyed this video or learned something new, please share it with a friend or colleague. Learn more on tackling racism in healthcare at healthaffairs.org.